Good morning, everyone. Thank you all for joining the session this morning. My name is Haiti Del Toro with UHealth Compliance Educational Initiatives. As you may have noticed when you joined the meeting, this session is being recorded, and that's really for the benefit of everyone on the call to have as a resource later on, as well as for anyone else that may not be able to join us at this time. I would like to introduce you to Becky Jacobson, who will be presenting. Becky is the Director of Professional Services at Panacea. And before we get started, I'd like to ask that you please hold off on your questions until the end. You can go ahead and ask them at that time, or you can post them in the chat and Becky will respond, or we can always respond via email after the session. So Becky, whenever you're ready.
Perfect. Thank you, Haiti. Good morning, everyone. I heard someone say, "Good morning, it's 7 a.m." I'm in a different time zone, so it's a little earlier here. um, so, welcome. We're going to talk about some coding, billing, documentation, some updates. And I did also ask Dr. Levy a question right away this morning when we came on because I have a interesting tidbit of information for you that I'll sneak in during the session. So, I want to talk first about the disclaimer. Everything in the presentation is based on Centers for Medicare or Medicaid Services, or we know them as CMS. In lieu of CMS having a guideline, we do then rely on the American Medical Association or the AMA. I always like to preface my presentations with please don't shoot the messengers. So, we don't make these rules. We just interpret them and educate on them. So, the first thing we're going to talk about is teaching physician guidelines as this relates to evaluation and management services. So, there's a couple of things that we're looking for in those attestation statements. The first is that the teaching physician performed key portions of the service either at a separate time on the same date of service as the resident, or that the teaching physician was physically present during the critical or key portions of the service. So, critical and key portions are not further defined in any of our guidelines. So, what CMS says is those are up to you, what you determine to be the critical or key portion of the service. The second part of the attestation statement is we're looking for the teaching physician's participation in the management of that patient. So with E&M services, the teaching physician does need to document their own attestation statement. That can be done by selecting a macro in the EMR. You can handwrite it or you can free text it in. Just make sure that it is being personally performed by you. I have a slide here with some acceptable documentation. The first is for an H&P, typically an initial inpatient or observation code. I performed a history and physical exam of the patient and discussed his management with the resident, reviewed the resident's note, and agree with the documented findings and plan of care. For a rounding note, we have hospital day number 4. I saw and evaluated the patient. I agree with the findings and plan of care as documented in the resident's note. And the last one, I saw the patient with the resident and agree with the resident's findings and plan. So it gets a little bit shorter when you are rounding with that resident or that fellow. Unacceptable documentation, you can see these are pretty short and sweet. They either do not show that the teaching physician saw the patient or the management of that patient, that the teaching physician was involved in that portion of it. So those are unacceptable. There is one exception as to when you can see a patient on a different date of service than a resident, and that is only when the resident admits a patient late at night. So you would be coming in the next day, probably rounding in the morning. At that point, we now have 2 separate dates of service because you're not seeing the patient on the day they were admitted. The resident admitted them the night before. So when this happens, the teaching physician must personally document that they saw the patient and participated in the management of that patient. The teaching physician's note must reflect any changes in the plan of care and the patient's clinical condition. We have to bill on the date of service that the teaching physician sees the patient, not the resident. So we're going to be billing 1 day after the actual admission. So an example here, I saw and evaluated the patient. I reviewed the resident's note from, and that would be the night before, so that date of service, and agree, except that the picture is more consistent with pericarditis than myocardial ischemia, will begin NSAIDs. So keep in mind that is only applicable when the patient is admitted late at night. Not applicable for rounding notes, etc. That has to be face-to-face on the same day. When we talk about teaching physician for surgical procedures, we have a couple of different types of procedures that fall into the guidelines here. What I want to say is a little bit later, you're going to hear me talk about global postoperative periods. That is not applicable here. It'd be easier if it was, but they don't equate the global period to what they consider to be a minor procedure for teaching physician guidelines. So what they say a minor procedure is, it's those lasting 5 minutes or less. For those procedures, you must be present during the entire procedure. We do recommend that the documentation reflect the procedural time. As a reader, we don't know how long the procedure took. Now, we do know, if the patient's under some type of anesthesia, it's typically longer than 5 minutes, but for those minor ones, which you guys probably don't do a whole lot of. For endoscopies, must be present during the entire viewing. You cannot view through a monitor in another room. You have to be side by side with the resident or fellow. And then for those surgical, high risk, and complex procedures, which is usually what you guys are doing, the teaching physician must be present during all critical and key portions of the service. Again, those are determined by you. And you also must be immediately available to furnish services during the entire procedure. So make sure for those procedures that, if you're not present during the entire procedure, that your attestation statement is that you were present during critical and key portions and immediately available to furnish services if necessary.
Hey, Becky,
Overlapping. Yes.
just a quick question.
Yes.
You don't have
Yes.
to define what those critical components are for billing purposes, correct?
You do not. No. Your attestation statement can just say that you were present during the critical and key portions, and that is determined by you. So, yep. For overlapping surgeries, for a single surgery, when the teaching surgeon is present for the entire surgery, the presence can be documented in the note by the physician or by the resident, but that's only when you're present for the entire surgery and you're only teaching one resident or fellow. For 2 overlapping procedures, you must be present during the critical or key portions of both of those procedures. So, of course, they can't take place at the same time. The teaching physician has to personally document that you were present during the key portions of the surgery. However, for this one, for 2 overlapping, you may have a covering qualified surgeon. So when that happens, we do recommend that your attestation statement state, Dr. X was covering for me. And then we also recommend that covering surgeon come in and document that I was covering for Dr. whoever. For 3 overlapping surgeries, those are not payable under the physician fee schedule. So maximum for teaching for surgical procedures is 2 for payment purposes. So those attestation statements must be documented by the teaching physician. They must be dated, contain a legible signature or identity. Again, hand typed. You can use a macro or you can hand write, also if you're still writing. So let's switch gears from residents and yes, go ahead.
Again, go back one slide. So if you are involved and have 2 surgeries that are overlapping, and then at some point at the end of the day, 6 p.m., there's a multi-surgeon team working on an incredibly complex case, and they need you for 25 minutes, and your cases have sort of finished. But that case has been literally going for 14 hours. Is that a problem to sort of jump in at the very end of a case? Your cases are done, but if you look at the start and stop times, you could conceivably think that it's 3 overlapping rooms, but you're really just involved at the very end of a very complex, long procedure.
Yeah, so what I would recommend in that situation is that you document what time you walked into that third OR. And what that does is it takes any ambiguity out of the situation, where if they are reviewing you for concurrent cases, that we can look and we can see the anesthesia stopped, for this patient, these other two patients, let's say at 2 o'clock and 3 o'clock in the afternoon. Now I'm looking at another note, and this provider says that they walked into the OR at 4 o'clock in the afternoon. So I would take the ambiguity out of it, just to ensure that there would never be any questionability about it. Okay, so let's move into shared split care. So completely different from teaching physician guidelines. Shared split care is when a non-physician practitioner, so what we're talking about here is PAs or NPs. And what happens is one of those types of providers and a physician are seeing a patient on the same date of service. So with billing, this gets to be interesting because we have two choices. We can either bill under the NPP or we can bill under the physician. We really want to try to bill under the physician because we get 100%, where with an NPP it's 85. So when we look at these types of visits, we can only bill them under the physician's name if the physician provides a medically necessary face-to-face portion of the E&M encounter. Again, this does not need to be at the same time with the NPP. It can be later, but on the same date of service. The physician must personally document in the patient's record the details of their face-to-face portion that they had with the patient. That's usually where we're lacking. You can't use a resident or a fellow attestation statement here. You have to document your details of what you did with that patient when you were face to face. If we don't have that documented, then we can only bill the encounter under the NPP. So make sure that when you go in and you see the patient, if you reperformed the entire exam, document that. If you reperformed just, let's say, cardiovascular and respiratory part of the exam, document that. If there's any change in the plan, make sure that you document that as well, and then attest to the NPP's documentation. So you want to be a little bit more robust with attestation statements here. There's a little hiccup here in that when you're working in the hospital setting, you have to know the employment relationship of the NPP, because that any NPP that's being utilized must be an employee of the clinical department or UMMG practice and linked to that provider group. So if the NPP is employed by the hospital, you can only use their review of systems, past medical, family, and social history. So make sure that you know the employment status of those NPPs as well, so that you don't get into some trouble here. So let's move into critical care. Near and dear to my heart, I'm a critical care trauma nurse. It's a huge adrenaline rush for me. And like I like to say, I have retired from nursing, but this pandemic has thrown a wrench into things, and I've actually been spending the majority of my weekends in the trauma center now. So what I want to talk about here is when we talk critical care, we're really looking at the note to paint a picture. And we usually don't have an issue determining that the patient was critically ill or critically injured, or that the condition acutely impairs one or more vital organ systems, and also that there's a high probability of imminent or life-threatening deterioration. The problem comes in is that high complexity decision making to assess, manipulate, and support vital system functions to treat that organ system failure or to prevent further life-threatening deterioration of the patient's condition. So we really want to make sure that you're getting everything that you're doing, assessing, manipulating, and supporting. And that's usually where we fall a little bit short in the documentation. I have some examples on this slide of some vital organ system failure. That's not an all-inclusive list by any means. So the codes that we have for critical care are time-based codes. These are codes over the age of 5. 99291 is the first 30 to 74 minutes, and 292 is each additional 30 minutes. So with this, you do need to make sure that your critical care time is documented. If you are working with a resident or fellow during this critical care time, I do highly recommend that you state it excludes teaching time. And also, if you perform other billable procedures, you want to make sure that your critical care time states that it excludes other billable procedures. So slide 17 has what is included in critical care. If any of these are performed, you would add the time performing these to your critical care time. Anything else is separately billable. So just make sure that you exclude that from your total critical care time for billing purposes. A question that often comes is, can multiple providers bill critical care on the same date of service? Sure, they can. The problem with it is usually the one that gets their bill in first is going to get paid. Everyone else is going to get reviewed, and they're going to request documentation. So your critical care time cannot overlap. If you're providing it at 2 separate times of day, we do recommend documenting start and stop times. And providers in the same group have to add their critical care time together and then bill appropriately. CMS makes it pretty clear that every physician that's in the same specialty and subspecialty is treated as one physician. So that's why we need to add that all together. And a little side note, critical care cannot be shared or split with a nurse practitioner or a physician's assistant. It's one or the other. I do have pediatric critical care codes in here just in case you ever encounter these. The guidelines are the same for meeting the guidelines for critical care. These are based on the age of the patient, and they are per day codes. So only one provider can bill for these. If other providers are seeing the patient, they would bill the hourly critical care codes on the previous slide. And then when the pediatric or neonate patient gets better, we do have intensive care services. So patient doesn't meet critical care guidelines, but they still need intensive observation, frequent interventions, and other intensive services. These are the codes that would be billed. They are based on the weight of the patient, so we recommend weight is documented. And again, these are per day codes as well. So just in case you ever encounter those. Let's talk about modifiers. So we have payment modifiers for evaluation and management codes. Those are 24, 25, and 57. So 24 says that you are performing an unrelated E&M during the postoperative period. This only goes on the surgeon's E&M codes. And a lot of providers say, how do I know? How do I know if I can bill an E&M in the postoperative period? And I always say, ask yourself a question. If I had not performed surgery on this patient, would the patient still be seeing someone for this problem? If the answer is yes, then you should be able to code your E&M. If the answer is no, this is from, they wouldn't be seeing them, it's a result of the surgical, then it's part of the global postoperative period and not billable. Modifier 25, highly audited, has been on the OIG list for audits for the last 3 years, and it still is there this year. This is a significant separately identifiable E&M on the same day as a procedure or other service. It goes on the E&M with a minor surgical procedure. And then the decision for surgery is a 57, and that's a major surgical procedure. it only goes on the E&M code if the decision to perform the major procedure was done the day before or the day of the procedure itself. So when we're applying these modifiers, you do need to know the global period of the procedure in order to know which modifier goes on. Modifier 24 goes on the E&M for either a minor or a major procedure. Modifier 25 is applicable only when you're performing a minor procedure, and 57 is for a major procedure. So digging a little bit deeper into that 25 modifier, a couple of things NCCI edits, which is what we run everything through to look for bundling issues, if you ever hear anyone talk about bundling. So what NCCI says is that the decision to perform a minor surgical procedure is included in the payment for the procedure itself and should not be separately reported as an E&M. However, if there is a significant and separately identifiable E&M service unrelated to the decision to perform that minor procedure, then it is separately reportable with a modifier 25. This is where the conflict comes in. Oftentimes, providers make it look so easy when they're making the decision to perform that minor procedure, and then they go ahead and they do it on the same date of service. And in the back of my mind, I think it probably was not that easy, but the documentation makes it look like it was. So you really want to make sure that you're being very robust and you're only using those elements that are unrelated to the surgical procedure to determine your level of service for the E&M. NCCI further goes on to say it doesn't matter if the patient is new. That alone does not justify reporting an E&M code. We do understand that there's more work that goes along with that, but it doesn't make a difference according to what NCCI says. So a little bit further here, every procedure has pre-service in the fee. Additional E&M services, if you are going to be billing those with a 25 modifier, make sure that the extended work is medically necessary. So don't, evaluate other body areas or organ systems unless there's a good reason for doing so, and that's documented. The medical necessity for the E&M and the procedure must be sufficiently documented in the patient's medical record in order to support the need for that modifier 25. So global fees, I said we were going to talk about these, what's included. A 0-day global, there's no additional pre-op or post-op days, but an E&M on the same day is typically included. For a 10-day global, no additional pre-op day. Post-op days are 11, the day of surgery and 10 days post. And the E&M on the date of the procedure is typically included as well. And for those 90-day globals, 1 day pre-op is included. So remember when I said if the decision to perform the major surgical procedure is done either the day before or the day of the surgical procedure, you need to bill your E&M and put a 57 modifier on it, otherwise it bundles. So for 90-day globals, post-op days is 91, the day of surgery, 90 days after. The E&M resulting in the decision for the surgery is not included. So that's where your 57 modifier comes into play there. Co-surgeons and team surgeons, very applicable to you guys. I just finished a big neurosurgical audit for one of our clients, which is why I asked a question prior to starting this, because I'm going to talk about that for a minute when I get to surgeries here. So for co-surgeons and team surgeons, co-surgeons is a modifier 62. It goes on the same surgical CPT code, meaning that you and another surgeon are performing the same surgical procedure, but you're working together to do that procedure. So you both bill the same code and you put modifier 62 on. Modifier 66 is for team surgeons. That's more than 2. Everybody needs to put a 66 on. If you are working with another surgeon and it's not the same CPT code, then each surgeon bills their separate CPT codes without a modifier. When it comes to documentation for co-surgeons and team surgeons, each surgeon has to document their own operative note, and you have to each describe your role in the performance of the surgical procedure. So please don't copy and paste another surgeon's operative note under your name, because that's not going to suffice. We need to know what each of your roles were in that procedure. The other thing about yes, go ahead.
I apologize. I'm the only one asking questions. I guess I'm the only one who doesn't know enough about this. But there are two questions that relate to that. One is when you are doing a co-surgery with another faculty member, and you're billing as a modifier 62 for the same CPT code. I heard that you have to document in a teaching institution that there wasn't availability of a trainee or something of that nature. Is that true or untrue?
That is true. The same thing falls into play, whether it be a co-surgeon, a co-surgery, team surgery, or assistant. So an assistant surgery, if you are an accredited teaching facility and you're typically working with residents or fellows for your surgical procedures, you do need to document that a qualified resident or fellow was not available.
And the second part of the question is, we often do spine surgeries with exposure surgeons. And my understanding here is that they cannot bill for like a retroperitoneal approach, even though that's what they're doing, but they have to either take a CPT code or co-surgeon a CPT code from the spine code. That's correct. They cannot, bill for retroperitoneal exposure.
You are correct. There is no CPT code for it. So yes, they typically need to take the CPT code that's actually being performed for the spinal procedure, and they have to code it as a co-surgeon. Yes.
Got it.
Okay. So the other thing that I want to say about any surgical procedure, whether it be co-team or assistant surgeons, please make sure that you document the medical necessity as to why that extra set of hands or hands are necessary. A lot of providers say, well, we look at the Medicare physician's fee schedule indicators for assistants and for co-surgeons and for team surgeons, and we have 3 different numbers that we look at. None of those 3 indicators say an assistant at surgery will be paid. They all say may be paid. So we always want to make sure that we have the medical necessity for that, extra set of hands working with you documented. If there's one thing you walk away with, make sure that you get medical necessity in those op notes for co's or assistants. One other thing that happens quite honestly with neurosurgery especially is for assistants or for co-surgeries, there's 2 different sets of guidelines. CMS and AMA differ for co-surgeons. And the AMA has, in the CPT book, has a whole bunch of CPT codes that a co-surgeon is allowable. But when we go and look at the Medicare physician fee schedule indicators, it says they're allowable, but only if they are a different specialty or subspecialty. So if there's 2 of you working together, 2 neurosurgeons, and you're in the same group practice and you carry the same credentials from a specialty and subspecialty, from the CMS perspective, it may not be paid. So I recommend, if there isn't, and I'm sure, compliance can probably expand on that to see if there's something a directive to the coders on how they handle that. But there's a huge difference for those neurosurgery and spinal surgeries that AMA and CMS differ. Not that you need to worry about it. You document exactly what you do, get your medical necessity in there. and then, let the coders and the billers deal with it on the back end. For assistance,
I'm sorry, Jacques Morcos here. Can I ask a follow-up question to this? I don't know if you're going to cover it or not. Would then use of modifier 22 indicating that this case was particularly complex? Number one, does modifier 22 always trigger a manual review before it gets paid? And that's why we have to, we usually justify at the beginning of an op note a paragraph saying why this particular case was complex above and beyond. And number two, if we have to use a partner of the subspecialty on this particular case, then does modifier 22 help us use modifier 62 to justify the complexity of the case?
Okay, so modifier 22, the answer to your first question is yes. It typically gets kicked out for a manual review from a reimbursement perspective from the payer. So usually when modifier 22 is on a CPT code, the records do need to be sent in. So you always want to make sure that you're documenting the over and above complexity of the case. When it comes to co-surgeons or team surgeons, a modifier 22 isn't going to make or break the documentation having to be sent in for review. So just make sure that you document whenever you're working with someone else, that you document why you need that person. So, a lot of it with neurosurgery, from my perspective, it doesn't take a rocket scientist to figure out that there was more than one surgeon needed for some of those cases. So, but you have to remember, some of these payers that are looking at your notes really don't have a clue what surgical procedure you're doing or how invasive or how in-depth it is or complicated. So you just want to make sure that you're being really robust with your documentation and documenting the medical necessity anytime there's extra hands that are needed. Okay. So
okay, I'm sorry. One quick point then. If we use modifier 22, do we put somewhere in the op note, or do our billers mention what percentage extra work that presented? Is it routine or common to say, well, this is 25% more work than the average case? Or do we leave it up to the payers to decide how much more they're going to pay?
Yeah, typically the payers are going to make their decision. It doesn't matter. I have providers, I don't have them say the percentage, but there are providers that do state, the procedure took 2 hours longer than typical procedures of this nature due to, extensive adhesions or due to the patient's body habitus or things like that. I do have them, or the patient's a bleeder, a severe bleeder, and it's taking a lot of, time to get in there and take care of all the bleeding aspects. So they usually will put in, how long additional it took compared to their typical procedure. But on the back end, I don't want to speak because I'm not sure. I'm guessing that there is some kind of, policy that's set in place for the coders and the billers on how much that fee gets increased if a modifier 22 is on that code. So, and that's more on a back end process.
Okay, thank you.
You're welcome. So assistant surgeons, typically the same thing, but I do minimum assists, that modifier 81, don't really see a whole lot of those anymore. But modifier 80 is an assistant surgeon. Modifier 82 is an assistant surgeon when a qualified resident is not available. So as an accredited teaching facility, if you're typically working with residents and fellows and you're using someone else as an assist, whether it be a physician, that is going to go under modifier 82 if there's a resident or fellow not available. Modifier AS is for a PA or an NP only, and that's when they're acting as an assist. So when you're working with assists, again, the same thing. There's only one operative note, that's the primary surgeon's. Make sure that you document the assistant's name and their credentials. Why were they medically necessary for the procedure? How the assistant participated in the performance of the procedure, and that a qualified resident was not available when applicable. The reason why we're asking you to document how they participated in the performance of the procedure, we need to make sure that those assists are actually working in a capacity that's more than just an operating room technician. And that's why they started asking for this additional documentation. So make sure you're getting all 4 of those documented. Modifier 59 are our X modifiers. So you heard me say bundling before. This is a bundling issue. It's when there are procedures that are performed on the same date of service and we have separate CPT codes for them to show exactly the work that we did. However, what they're saying is that one or more of those procedures are overlapping and they bundle. We can use Modifier 59 or these X modifiers to unbundle those procedures, but it is only applicable to use those modifiers if the documentation shows that they were performed at a different session, a different procedure or surgery, a different site or organ system, or a separate incision, excision, lesion, or injury. These are procedures that routinely are not done on the same patient at the same time. So, if it's standard for you to always do those 2 procedures together and they're bundled, we don't want to unbundle them. That's going to get us in a little bit of trouble. So I do have Modifier 59 is for our commercial payers. Medicare has these X modifiers. By the way, they're not mandatory yet. They're asking us to use them. They are a little bit more descriptive than just 59. So what we have here is XE is a separate encounter. So that means that the patient went back to the OR maybe. An XP is a different practitioner. XS, a separate structure. So that means that the procedure was performed on a separate organ or anatomical structure. And then we have an XU, which is an unusual non-overlapping service, distinct because it doesn't overlap with the usual components of the main service. So again, trust that your coders are going to be running things through NCCI edits. They're going to be looking at the documentation to see if it does meet the guidelines for 59 or X, and then they will pen those. So we do check the NCCI edits on every surgery that's billed, and we use Modifier 59 or the X modifiers only if the procedure is bundled and the documentation shows that it is distinct. So that's where those come into play. One slide here on what's included in surgical work: preoperative services after the decision for surgery, all those intraoperative services that are part of the surgical procedure, any additional medical services required during the postoperative period, including complications. Now, if a complication does require a trip back to the operating room, then that second surgery is payable. So, but only if you're going back to the OR. Routine post-op visits, pain management is included, and then our miscellaneous services, dressing changes, removal of sutures, staples, etc. So some takeaways from modifiers. Payment modifiers are always placed on the claim before informational modifiers. Overuse of any of the modifiers can flag you as an outlier, so you want to make sure that your documentation is pretty clear. Ask yourself, is it a separate encounter, a separate practitioner, separate organ or anatomical location, or is this really unusual? I typically don't do these 2 procedures together. So I asked about stereotactic neuronavigational, if you guys are utilizing that at all in any of your procedures. And I want to tell you, I just finished a very large audit for this on one of the largest third-party payers that we have out there, and they're requesting payback for that code. And there's a couple of things I just want to remind you from a surgical perspective when you're dealing with those is if you need to document your pre-planning, whether it's CT, MRI, make sure your operative note in the beginning, you get your indications for the procedure, you get your informed consent, all that kind of stuff. And then make sure that you're talking about your pre-planning that was done via CT or MRI. Make sure that you use the words stereotactic neuronavigational device was brought in. The MRI, the CT, make sure that you're using those keywords in your documentation. What I found with this review is that their documentation really didn't support the coding for that stereotactic neuronavigational device. And so this particular client is really looking at a pretty large payback based on that. But when I see that it's a large third-party payer that's doing the audit, it usually means that it's going to float out from, location to location. So just be careful with that one. That's an extra tidbit for you. I want to talk about the E&M
I'm sorry, quick question again regarding that
Yep.
code. If there is an ENT and a neurosurgeon doing a case, can the ENT use, I think it's 61780, the extradural navigation, and the neurosurgeon use intradural navigation 61781?
They should be able to. It's, because they are, we have two different specialties, okay? So I don't think you just need to make sure that the documentation, that both surgeons are documenting appropriately to support the code that's being billed. And that's, a lot of what we look at from a compliance and coding and auditing perspective, we really say it's all in the documentation. It's all in how you document. So what I'm telling you, what I found with this audit that I was doing, one, I couldn't find any pre-planning anywhere in the patient's chart, and I dug. So I was questioning, first off, is this really what they were doing? They weren't using the key words. They weren't using stereotactic neuronavigational in their op note at all. And then I couldn't find the pre-planning. So I'm like, yeah, you probably didn't do this. And I know when those codes first came out, they were highly overutilized. And I have a feeling the payers are now catching up on that. So just make sure the documentation is sufficient to support what codes are going out the door. And you should be fine. Okay? So the E&M office visit update, this is a quick brush over of what changed in the office and other outpatient E&M codes effective January 1st this year. I'm sure Haiti will let you know that there is a separate presentation and where you can find that. There's also one on inpatient services as well. So a couple of things to talk about with these new guideline changes. One, our number one guideline of medical necessity is the overarching criteria for a level of service never went away. That's still our number one guideline. So the documentation has to support medical necessity for all services rendered, whether that be an E&M, a procedure, or a diagnostic test. What happened with these revisions, in the office or other outpatient service codes, they eliminated the history and physical exam as elements for code selection. That doesn't mean you don't document what you do. Just document what you do. We're not counting those bullets anymore for the level of E&M. We now look at medical decision-making or time as the factors for the level. They deleted code 99201, and we have two new prolonged care service codes that have shorter time increments with them. So with that time, if you're using time for your level of service, counseling and coordination of care is no longer required, so that, total visit time was 30 minutes, greater than 50% was spent in counseling coordination of care. That's not necessary anymore. It's total time. We cannot include time spent on separately reportable services. So again, make sure that you state your total time excludes other billable services. It includes the total time spent by the physician or other qualified healthcare professional, both face-to-face and non-face-to-face, on the same date of service. It does not include time in activities performed by clinical staff, and it does not include teaching time. So residents and fellows, we can't use their time for anything, quite honestly. Here are the time ranges for each one of the E&M codes that are out there. So these, and their time ranges now, they went from typical time to time ranges. So these are the times that we're looking for. The Prolonged Care Service Codes, AMA has 99417. You can only use these with the highest levels of service, and only if you are coding those based on time. So you have to code either a 99205 or a 99215 first. It includes time on the same calendar day of the office visit. And for the AMA, the time is calculated in 15-minute increments beyond the minimum time required. So for Prolonged Care Service Codes, this kicks in at 75 minutes for a new patient and 55 minutes for an established patient. The only difference with CMS is they have a G code instead, G2212. And the only difference is that the time is calculated in 15-minute increments beyond the maximum required time. So here, for a new patient, you have to meet 89 minutes instead of 75 for a new patient. For established patients, you have to meet 69 minutes instead of 55. So a little bit more in depth for CMS. I have a comparison table in here, difference between AMA and CMS for those codes. So for time, counseling and coordination of care is no longer necessary. You count the total time, the rendering provider's total time, including non-face-to-face time on the same calendar day as the visit. You can add on your prolonged care service codes if applicable. You cannot include time spent on separately billable services or ancillary staff or teaching. If the patient is being seen by two providers, a physician and an NPP, you cannot bill for the same minute of time. So if that does happen, we do recommend that you document start and stop times for each of those providers, just to make sure that we're not overlapping. So if you don't use time and you want to use medical decision making, each of the four levels are comprised of three elements. So medical decision making overall is based on three elements. You have to meet two out of the three to determine your overall level of medical decision making. We have the number and complexity of problems addressed during the encounter. You're seeing that addressed during the encounter in bold. That is new to these guidelines. We always had the number and complexity of problems. They're now specifying addressed during the encounter. The second one is amount and/or complexity of data to be reviewed. They added and analyzed. And then we have the risk of complications, morbidity, or mortality of patient management decisions made at the visit. So remember, your overall medical decision making requires two out of the three of these to be met. Slide 44 shows what fits into each category as far as complexity goes. So you look at what types of problems you're treating, and they fit into one of these areas. I do want to point out the difference when you're talking about stable chronic conditions Level 3 is stable, 1, stable chronic condition. Level 4 is 2 or more stable chronic conditions, or a chronic condition with exacerbation, progression, or side effects of treatment. And a level 5 is a chronic illness with severe exacerbation, progression, or side effects of treatment. So you want to make sure that your documentation is stating if there is an exacerbation. Is it a mild exacerbation? Is it a severe exacerbation? You want to use those keywords. We do recommend that you document the complexity of your problems and the reason why they fit there. So if you put down complexity, moderate, 2 stable chronic conditions, that's perfect. Take out the ambiguity, because not all conditions are going to fit nice and neat into what they have outlined here. So complexity is really, we want to take the subjectivity out of it from a reviewer perspective. So that's complexity when we talk about data. So we now have the data divided into 3 categories. Tests, documents, orders, or independent historians is category 1. Category 2 is independent interpretation of tests. And category 3 is discussion of management or test interpretation with an external physician, qualified healthcare provider, or an appropriate source. For those tests, documents, orders, or independent historians, each unique test, order, or document source is counted. So we all know a CBC and a CMP are 2 different tests. That would be 2. If you order a CBC and you review a CMP, that's 2. It's 2 different tests. You can't take credit for order and review on the same data service. You only get one bullet in that area. So when we look at different levels of service, a level 3 has limited data to review. You have to meet 1 out of the 2 categories. So category 1 is tests and documents, and it's any combination of 2, from the review of external notes from each unique source, the review of the results of each unique source, each unique test, or ordering of each unique test. Any item counts as 2. So if you're reviewing external records from Hospital A and Hospital B, you want to make sure you're being that specific, because that's 2. If you, review a CBC and a CMP, that's 2. You want to make sure that you state you reviewed the CBC, the CMP, the TSH, whatever it was. You need to get down into the nitty-gritty as far as uniqueness here. So make sure that you're listing out your unique tests. Category 2 is assessment requiring an independent historian. A historian is anyone who provides history in addition to or on behalf of the patient. Document who you're getting that from and what you got from them. Okay. For a level 4, we now have 3 categories. You have to meet 1 out of the 3. What happened is they took category 2 from level 3 and moved it into category 1 for a level 4. Everything else remained the same. Now they added a new category 2, which is independent interpretation of a test. It must be performed by another physician and not reported separately. So if radiology has a CT that they did the formal interpretation on, and you bring those images up and you look at them and you give your own independent interpretation of such, that is where this counts. So make sure that you're, state my personal review of the images. I reviewed the images. Be very specific with that. Category 3 is discussion of management or test interpretation with an external physician. That is a different group or specialty and or an appropriate source. So a couple of things here. You cannot count tests in that category 1, that are billed by the same physician or group practice. So if you're billing for that test, we can't count it. If someone else in your group billed for that test, we can't count it. Okay? Same thing. If someone else in your group ordered it, we can't count it. The same thing with independent interpretation. If that interpretation, we can't count it if it's billed by the same physician or group practice. So keep this in mind if your patient is seeing a couple of you in the same specialty and subspecialty. The discussion with external physician, it's a physician outside of the practice or a different specialty in the same practice. So I get a lot of questions on that. Ophthalmology and optometry is one that asked me. Yes, that's applicable right there. You're different specialties. You're in the same group, but you're different specialties. So with a level 4, you have to meet one out of those 3 categories. Level 5, same categories as level 4. You need to meet 2 out of the 3. So a note here, a historian cannot be an interpreter. That has not changed. Data elements, such as labs or other test results that are carried forward from note to note, no longer count in data review. So you only get credit for those that are new studies, new orders, or new reviews on that data service. Okay. Risk levels. A lot of different risk levels here. I'm not going to talk a ton about all of them. Each level of service is next to them. What I want to say is they did say and made it very clear that risk is determined by the provider based on the patient's overall condition and management. So what am I going to tell you? Document your risk. Take the subjectivity out of it again. I think probably the majority of your patients, I like level 4. It has prescription drug management in it. You don't need to add, change, delete, modify. It all fits into prescription drug management. I want to talk about risk factors. Make sure that you're documenting any risk factors that the patient has. Those are over and above the typical risks. So if your patient has COPD, sleep apnea, hypertension, they're on a blood thinner, those are all additional risk factors. Make sure you get them documented. A new level to 4 is a new risk level here. Diagnosis or treatment significantly limited by social determinants of health. Living conditions, financial issues, transportation issues, insurance issues, that's where these would fit. So that's what falls into that level 4. And then a level 5, not a lot has changed here. Do want to talk for a moment about the drug therapy requiring monitoring for toxicity. They did state that this is not for therapeutic efficiency. What we're looking for is adverse effects. We look for long-term monitoring, not less than quarterly. It can be done by a lab test, a physiological test, or imaging. Monitoring by history or exam does not qualify. So they did make some changes there. Then another one here is that's new is decision regarding hospitalization. Patient does not need to be hospitalized, but if there is a discussion and decision made regarding that, make sure that you document that. So again, I do want to say that risk is determined by the provider, and it's based on the provider's clinical judgment of the patient's overall condition. So take the subjectivity out, make sure you document. I recommend complexity and risk. Leave the data up to the coder or the auditor or the reviewer to dig into those types of things. So a little side note here for diagnosis and management options. Only those diagnoses that are receiving active treatment count towards the level of service. So you used to hear us say, a new problem with or without additional workup, that doesn't matter anymore. Make sure that your assessment is number 1, number 2, number 3, number 4. Your plan, number 1, number 2, number 3, number 4, because we need to show that you're actually actively treating or managing those problems, each one of them. We can no longer just copy and paste the patient's medical history into the assessment and call it good. That's not going to suffice. You need to show that you're managing or treating them. So the table of risk, again, provides examples only. So you just want to make sure that you're getting your risk appropriately documented. I have the conversion factor update in here. Google's, of course, we kind of giggle at it. It decreased again. There's an increase in RVUs for office visits and emergency department codes. That's because of the guideline changes. And they're trying to bring the ED up.
Becky,
Yep.
hey, it's Alan
Yep.
Levy. Sorry to interrupt you. We're 8:03 and we do have a speaker at 8 o'clock. So
Okay.
just FYI.
No, I just wanted to tell you the administration codes and the CPT codes for all of the COVID vaccines are in here. And you will get a copy of this presentation as well. And then I have one last slide. Codes were deleted due to low utilization. So this is as of January 1st. These 3 codes are no longer applicable or billable. They have been deleted. So just an FYI for those updated codes for 2021. So Haiti, I'm turning it over to you. The sun came up here. I'm happy. So thank you, everyone.
Thank you, Becky. I know that you guys need to get on another meeting right now. So in the essence of time, I'm just going to go ahead and send to Maggie the information that she can share with the group as far as to where you guys can access the information on the evaluation and management code update, CBL. So thank you all again for attending. We appreciate it. Thank you, Becky.
Thank you, everyone. Have a great weekend.
Thank you very much. Well,
Matthew Rosenberg has a question.
I'm still here.
Sorry, my question can wait. I'll put it in the chat.
Sounds perfect,
Kathy,
Katie.
Dr. Rosenberg, can you please go ahead and send that to Maggie? She can forward it to us and then we can respond to the question via that route.
Perfect. Thank you.
All right. Thanks, everyone.
thank you.
Bye.
Well, good morning, everyone. Yes, the complexity and documentation of, of all the things that we're doing now at the medical school seems just getting more and more complicated. And even doing research is getting more complicated, as you appreciated all the forms. But it's great that you have the experts that can provide the information that you need to do to follow in your everyday clinical work. But today, it's my pleasure to introduce Dr. Vance Lemon. Vance is the Walter Ross Distinguished Chair in Developmental Neuroscience. We're very fortunate to recruit Vance several years ago to the University of Miami. He's really made a big difference, not only in the Miami Project and Department of Neurological Surgery, but throughout the whole medical school. And said Professor of Neurological Surgery, important component of the Miami Project drug discovery program. So we'll talk probably a little bit about that today. But I'm really looking forward to hearing about what he has to say about the future of axonal regeneration, a very basic premise in terms of improving function in people living with different types of neurological disorders and disabilities. So Vance, thank you very much for speaking today and look forward to your presentation.
Thanks, Dalton. The main take-home message, I'm going to tell everybody that the main take-home message at the beginning is when somebody sends you a long email inviting you to give a talk 2 years in the future, read the whole email. I didn't do that when I was invited to give a keynote talk at a meeting in Houston in March. And so I'm going to present that presentation that I gave in March today. And in January, I went back and wondered what happened to this meeting. Is it gone virtual? Is it canceled? And I went through my emails and I read the email and I saw that I had agreed to have a debate with Wolf Tetzlaff from ICORD. He's the director of ICORD at the University of British Columbia on what regeneration would look like in 2071. And I immediately thought, what? how could anybody be expected to predict anything 50 years in the future? This is ridiculous. But apparently I had agreed to that. And so then I said, okay, well, I guess I need to get to work. Something that just happened this week that I want everybody to know about is the medical school is purchasing a new phenotypic screening microscope. This microscope is a confocal microscope, and I purchased it intentionally so people here could screen organoids, the kind of work that goes on in Mike Ivan's lab. It should be here in 2 months. And so if you have projects that you think that would be doable on this, we'd love to help you. And I just wanted everybody here to know that. We just got the PO yesterday, so I'm very excited. We have some disclaimers. So Wolf has agreed to let me use his presentation today. He's a co-inventor on some patents. I'm a co-inventor on some patents involving kinase inhibitors and nerve growth. I'm involved in a couple of startups, one that's relevant to the talk today. And we're both involved in open data commons for spinal cord injury, where we're trying to collect preclinical research data at the level of individual animals. So why was I invited to give that talk? I think it's because a couple of years ago, there was a meeting in Bethesda called SCI 2020, called Launching a Decade of Disruption in Spinal Cord Injury Research. I went to that meeting, as did a lot of preclinical researchers, and I was kind of shocked that there were so many important stakeholders who were not represented at this meeting, such as neurosurgeons, big pharma, the companies that make devices. And so I thought that was a huge missed opportunity. And so I'm a little bit outspoken, so I wrote an article about it, and I was able to get it written and published within 2 months. And so that's why I think they invited me to be involved in this, because they know I'm outspoken. The other person, Wolf, is famous, notorious for being outspoken. About 10 years ago at the Silomar Conference on Nerve Regeneration, he was involved in a debate, and he demolished the other team. And he was so aggressive in his approach that now I think he feels he maybe went a little over the top. But there was no way I was going to debate Wolf, having seen his debating style. So we did a little negotiation, and we decided to collaborate on this and have a discussion rather than a debate. So what does Wolf and I mean when we talk about regeneration? We're really focused on axon regeneration. We both work on spinal cord injury, but there's lots of other places that are maybe relevant that we're not going to really talk about so much, but where axon regeneration would be important. And for sure, we decided that neuroplasticity was just out of scope for this talk. There was just too much to cover. A lot of the things that I'm going to talk about are relevant to neuroplasticity and these other forms of nerve regeneration, but we're going to be really focusing on CNS axon regeneration. I'm kind of going through the intro, but we decided if we were going to look 50 years in the future, we needed to start out by looking 50 years in the past, see where the state of nerve regeneration was 50 years ago, then look at it now, and maybe that would help us think about the arc for 50 years from now. So here we go with 50 years ago, 1971. In 1971, I was in college, and I was working as an undergraduate in a lab that was studying hydrocephalus. And there wasn't a lot of high-tech stuff then. Of course, we knew about DNA and RNA and protein, but the STS gel had just been invented. Southern blotting had not yet been invented. if we were looking at pathway tracing in the central nervous system, the only thing that was available were silver stains, which have been around for 50 to 70 years, and they were not very sensitive and they were very difficult to use. Single unit recording had been around for a while. Mini computers were just being applied to neuroscience, but they were not very powerful. You can see that instead of having lots of megabytes of RAM, it was measured in 2,000 words. That was what we had in the mini computer that I used when I was a postdoc. Epifluorescence was not a widely used technique. The dichroic mirrors that allow us to do epifluorescence had just been invented. When I was a postdoc at WashU, there was one fluorescence microscope in the basic science departments, and it was not an epifluorescence microscope. So doing imaging was very difficult 50 years ago. Monoclonal antibodies had not yet been invented. If you used an antibody in your lab, you made it. And Western blots were a long way away. So we didn't have a lot of tech. In terms of nerve regeneration, growth cones, people knew about growth cones, both from anatomical and in vitro studies. People knew that peripheral nerves could regenerate, and they were critical for limb regeneration. If you lopped off the leg of a salamander and removed the limb, the nerve, the limb wouldn't regenerate. So that was pretty interesting. Programmed cell death had been discovered, and NGF, the first growth factor, had been identified in the 50s. Roger Sperry, an amazing scientist at Caltech, had shown that there had to be some kind of signals on axons regenerating to neurons that allowed them to find the right place. So that was known. In fish studies, it was also known that axons from these giant neurons called Mantner neurons could find their way back to the right place. And people were starting to learn about reinnervation of the neuromuscular junction and autonomic synapses using physiological and some anatomical techniques. So that's 50 years ago. We knew some stuff, but not a lot. Okay, where are we now? We have phenomenal, crazy, amazing tools that are available for us to do research now. I can't emphasize how the internet has changed the way we do and think about things. It's true for everything, but it's especially true for biology. It's amazing. We have deep sequencing of DNA and RNA. We now have single cell sequencing. So my colleagues here in the Miami project are doing lots of projects doing single cell sequencing of spinal cords and brain to try and understand how the different cell types in the central nervous system respond to different kinds of injuries or diseases. We have brain-computer interfaces in humans. They're being used widely, including here at UM. We have super resolution microscopy. So we can see things down, resolved below 1 micron, the localization of things. We have light sheet microscopy. I'm proud that the University of Miami was the first university in North America to have a light sheet microscope. Thank you, Dalton. And we've been able to use that to image axons growing all the way from the eye into the brain. We have viral vectors, optogenetics, functional MRI, and PET. And people are making medical micro robots. The imaging that we can do both in the clinic and in the lab is fantastic and getting better and better all the time. I want to point out that MRIs and PETs have resolutions in the tens of microns. And so that's good, but it's not good enough for spinal cord injury, and you all know that better than I do. We have lots of tools that allow us to do cool experiments. We have CRISPR for targeted disruption or mutation. We have iPS cells, so now it's possible for labs like mine to do our experiments on cells derived from humans. And that's really important because so many things that are tested in rodents fail when they get to be tested in humans. So the sooner we can be testing in human-derived cells in the preclinical labs, the more likely we are going to be to have a successful therapeutic. We know lots about the structure of proteins. We have nanoparticles for delivering things in interesting places, amazing biomaterials. We have supercomputers that allow us to analyze the big data that's generated from the single cell sequencing experiments. We have powerful image analysis, and we have deep learning. And deep learning is something that now can be labbed and can be used in labs here at the Miami project. We do it in my lab. So that's a huge leap forward of the past 50 years. And so based on that, imagine what it's going to be like 50 years down the line. It's kind of the sky's the limit. In terms of regeneration, so I think we've learned so much in the last 50 years that with transplants of retina into the spinal cord, into the brain, we know that they can send out axons that grow to the right places. So even in adult, there are signals that axons can follow to find the right targets. We've learned lots about cell adhesion molecules, identified many more growth factors and axon guidance molecules. We've learned about the inhibitors like myelin and CSPGs that limit the ability of CNS axons to grow. And thanks to Kevin Park and Zhigang He, we now, about 12 years ago, made this incredible leap forward of being able to identify intrinsic factors such as P10 that, when manipulated, actually allow central nervous system axons to grow. And so for 100 years, basically there was no progress. And then all of a sudden, in 2008, with the discovery that knocking out P10 promoted axon growth, it's led to the identification of 20 or 30 more intrinsic factors that we can manipulate to promote axon regeneration. There's a huge amount of work on stem cells and how they can be used to repair the central nervous system. We've learned a lot about inflammation and the roles of the immune system and how they play out in influencing nerve regeneration. People are doing amazing experiments looking at the interaction between inflammation and the microbiome, and so this gut-brain axis. Many labs, there's going to be a talk at 4 o'clock today by Simone Di Giovanni on how epigenetics can influence nerve regeneration. So we're drilling down and learning why things like intense exercise can promote nerve regeneration. Is because it opens up certain parts of the chromatin to allow gene expression of regeneration associated genes. And so that ties in a lot with how important rehabilitation and extradural stimulation can be to promote regeneration. So tons and tons of stuff that's fascinating and all can work synergistically to help promote regeneration. The things that Wolf and I think that we still have a long way to go on. We think that we have still a very weak understanding of what's going on at the injury site. Although we've identified cells that are present, Dr. Bunge, who we're lucky to have here joining us today, has worked on the types how astrocytes can either promote or inhibit axon growth at the injury site. Kevin Park has shown that at the injury site, there's lots going on that limits the ability of axons to grow, but we also know that we don't know what's going on there. There's RNA, mRNAs, and microRNAs that are in axons, and we know that those are important in axon guidance during development, but they're still very poorly studied in regeneration, and maybe we need to know how to manipulate those. Lipids are traditionally poorly studied component of our cells in cell biology and biology in general. A lot because of mass spec and now fluorescence labeling of lipids, we're learning more and more. There was a talk at Baskin-Palmer about that this week, but we don't know if we're going to have to actively manipulate lipids in order to promote regeneration. And so that we need to learn a lot more about that. We know that mitochondria are very, very important in axon function. And if something goes wrong with mitochondria in axons, it can lead to degeneration. There are lots of inherited diseases where mitochondria are disrupted, and it leads to slow degeneration of nerves. Maybe we need to be able to manipulate, increase the number of mitochondria that are present in axons or promote their transport down axons to help enable axon growth. We don't know that yet, so that seems to be an area that we need to learn a lot more about. We know we don't need to get all of the axons to regenerate, to have nice recovery of function, but we don't know how many we need. And we don't know how far they have to go down the cord. Do they have to go all the way down the cord, or do they just have to go a few millimeters beyond the injury site in order to reconnect with central pattern generators? So we have a long way to go in answering those kinds of questions. When we were working on this talk, I spent a lot of time reading papers and looking at different topics, and I became alarmed because it seemed like lots of things that are highly relevant, specific topics, or even a general search like this on axon regeneration, the number of papers is going down. I can't understand how that can be, but I found it over and over again, and I have about 15 examples of that at the end of this deck. So for reasons that aren't clear to me, there's essential information that has either study sections are losing interest in it, the field's moved on to something else, but this is a problem. Okay, time to jump 50 years into the future. This is a card. I did a Google search of movies that were supposed to take place in 2071, and there were 2 hits, and one of them is my favorite anime, Cowboy Bebop. So I stole this image from Cowboy Bebop. So in 50 years, we're going to have single cell everything. Right now, we've got single cell transcriptomics, and people are starting to figure out how to do single cell proteomics. But we're going to have single cell everything. And we're going to have it at all ages, in all parts of our body, and in all disease conditions. And so that's going to be a real game changer. We're going to have super resolution location of everything. So we're not just going to know which proteins or RNAs are expressed in neurons. We're going to know where they are. Are they in the soma? Are they in the dendrites? Are they in spines? Are they at branch points or in the growth cone? And so we're going to know, and we're going to know who their nearest neighbors are. So that proximity of these biological agents that are the underpinners of axon growth, we're going to know pretty much everything about them. And so that's going to allow us to generate way, way, way more complicated models and be able to identify the key controlling points in the biological networks that are going to be the most efficient ones to target to get a biological outcome that we want. And so this is obviously, this isn't just true for spinal cord injury. This is going to be influencing how we understand all diseases and not just the central nervous system ones. Something that is kind of specific for the central nervous system is we're going to have connectomics of everything and at all ages. The technologies that are being used now, these serial EM reconstructions and the light sheet microscope, we're really going to know with high precision which neurons connect to which ones in the spinal cord. Pantelis Southoff is doing an amazing project with a former young faculty member here, Murray Blackmore, who's moved up to Minnesota, that's relevant to this in spinal cord injuries. Hopefully Pantelis is going to share that with us soon. Right now in 2021, the druggable genome consists of about 5,000 to 6,000 genes using small molecules and some cool methods for degrading proteins. But 50 years from now, all of the genes, all of the proteins that are expressed are going to be druggable using cool tricks. So it's going to give us more tools for manipulating the network to drive a biological outcome that we want. Wolf and I both independently tried to look into predictions about live cell imaging in humans. And we were shocked that people who are experts in the field think that in 50 years, we're going to have 1 micron resolution in living individuals using MRI and PET. In fact, they think it's not going to be 50 years, it's going to be 35 to 40 years. So that's still a long way away, but I think that that's super exciting. That means that for individual patients, the neuroradiologists, the neurosurgeons, the neurologists are going to have unbelievably precise knowledge about how an injury is at a given point in time, and that's going to allow you all to design much better, more precise treatments and interventions. And so that's probably the coolest tech for 50 years from now. We think we're going to have targeted delivery of drugs, not just that we're going to be able to administer drugs, but we're going to be able to target them to specific tissues and locations in the tissue. Biomaterials are going to be crazy amazing, be able to self-assemble. And we think that you're going to be able to generate new cells that you need from endogenous stem cells. We think 50 years from now, you're not going to be transplanting cells. You're going to be manipulating stem cells that are present in the tissue in order to produce the things that you want. Computational sciences, it's hard to imagine how sophisticated they're going to be. There's some things that Wolf and I think are a problem and that and make me a little bit nervous. So over the past 10 to 12 years, we've made a lot of progress in CNS, but it's still hard to get axons to grow more than a few millimeters. Nobody's been able to get them to grow many centimeters. If you look in some lower species like amphibians and fish, they grow kind of continuously over their life, and new neurons are generated, and those axons can grow meters to reach their targets and make appropriate connections. That happens in the visual system, and it's been pretty well studied. But there was a study done a number of years ago with adult sharks where they were given spinal cord injuries, and none of them were able to regain the ability to swim below the side of the injury. So that gives me a lot of pause. And so we still have a lot to learn. And here, even now, and people in our neurosurgery department are world's experts in this, PNS nerve regeneration is still really difficult. And it doesn't seem like they've made the kind of breakthroughs in the last 50 years that the CNS nerve regeneration people have. So maybe it's on the horizon, but that's distressing to me. Replacing local spinal motor neurons, for example, at an injury site, you might be able to generate some or transplant some in the near future, but having them extend axons lots of centimeters to the right targets is challenging. They go out and they seems like if they find empty synaptic space, they'll jump on it, they'll start to make synaptic proteins, and then they stop regenerating. So we need to figure out how to get them to ignore those inappropriate targets and go where we need them. And maybe a neuroengineering solution is going to be needed for some time using electrodes or something. But implantable electrodes right now aren't forever. This is something that is problematic, and maybe it's going to get better, but drug discovery is still really slow. And this has been studied intensely. Since it's slow, Big Pharma would like to speed it up. And what they have found is that it takes, on average, it takes about 25 years to identify an efficacious target for some disease process. Once they know a really good target, then the steps that they go through to develop a small molecule or a monoclonal antibody treatment are pretty well worked out. And so that part moves along quick. It's slow, but at least they know how to do it. But this is still difficult. And in 2021, they depend upon labs like Dalton's and mine and others here at the Miami Project to give them the viable drug targets. And most of them fail when they reach even before they get to the clinic. So this is a problem. And I don't know about Dalton, but my retirement funds have gone up over the last few years. I'm very happy about that. But and the number of papers on the human genome have gone up pretty well over the past few years. But the number of new drugs is just flat. From 1982 to 2019, it's about 30 drugs a year that come on. The rate of new biologics, so this mostly means antibodies, is going up. And I think actually in 2020, there were the most new FDA approvals of all time, but I think that a lot of that had to do with antibodies. So it's still a slow process. We haven't gotten more efficient at developing new drugs. We know in spinal cord injury that combination therapies are going to be required. People here at the Miami Project have worked on that idea for many, many years. But how do we figure out which combinations are the right ones to test? And how can they combine with rehabilitation, since we all now think that really aggressive, intense rehabilitation is going to be essential to have a positive outcome. So maybe we can do that by combining them with advances with neural engineers, but it's complicated. I want to show you an example of an experiment that we did. It's unpublished. So in our lab, we do lots of work with kinase inhibitors. Each of these bands running from left to right across the screen represent a bunch of kinase inhibitors that have very similar structures. And then the columns are different kinases, and yellow indicates that this compound inhibits this kinase very effectively. While over here, these compounds inhibit these kinases very effectively. These bands are all compounds that have different backbones and very different structures. These are ones that we knew from a big screen we did. They made, in vitro, they made axons grow longer. So these are some of our hits. And if for this particular compound, 931A, at 200 nanomolar, it increased neurite outgrowth by about 50% over background. And that might not sound like a lot, but that's better than any transcription factor we've ever tested. So actually that's good. That's a strong hit. Over here, 684, also at 200 nanomolar, doubled neurite outgrowth. So that's better than us putting together 3 transcription factors. So that's a really wonderful hit that we would want to investigate. So we did a combination experiment where we tested the 2 of them together at different doses. And we found something really interesting. We could take this compound, 931, and reduce its concentration 1,000-fold and get better neurite growth than either one of them alone when we combine it with 684 at 200 nanomolar. So that's fantastic, but it would be very hard to predict that. You have to do the experiment to find that sweet spot. I convinced my 2 colleagues, Hassan and John, to go big. And so we did an experiment where we did a 5-way experiment testing all possible combinations with 5 different hit compounds. And here the data is displayed a little bit differently. Each column is a single 5-way dose. And so in this case, it's these 5 GSK compounds at different concentrations, and it increased neurite outgrowth 400%. Over here, these compounds, they're doing something nasty. They're killing the cells. Well, many of these increased neurite outgrowth. So we would, again, you wouldn't be able to predict this based on the kind of knowledge that we have now. But we have the kind of technology, I showed that cool microscope at the beginning, where we can start to screen lots of things together and do dose response curves to do combinations. I talked to a lot of deep learning experts in preparation of this talk, and they think that if we can provide them data, this becomes a pattern recognition problem. And they believe that, you know, in a few years, if we are careful about collecting information from lots of different assays, from lots of different labs, they will be able to use deep learning to actually guess and predict which kinds of combinations would be rational ones to test, and perhaps even predict what kind of doses they should be tested at. So that I certainly don't understand the deep learning technology. That I'm just going to leave it at that. But experts seem to think that this is a doable thing. So it's going to be dependent upon spinal cord injury researchers producing data and putting it in open data repositories. This is kind of funny. Researchers are not scalable. And so how can we speed up what we do in the lab, since we have limited numbers of graduate students, postdocs, and faculty to work on these problems? Now, maybe we can speed up what we do using surgical robots. There are little surgical robots that you can buy that can speed up the drilling of places for inserting electrodes or pipettes into the skull. So maybe that would help us move quickly. We can do some of our behavioral testing using robots and video cameras, so we collect a lot more data a lot more quickly and a lot more accurately. We can use 3D imaging with light sheet microscopes, and a way to test lots of combinations in vivo is going to be with very cool 3D printed biomaterials that would allow us to put different combinations in each channel. And then if you found something in your section where there were lots of axons, you could cut that out and do mass spec on it to figure out what were the things present in that particular channel that worked really well. So that's some exciting work being done by Paul Dalton at the University of Oregon. And so this is how he envisions doing these kinds of experiments. Very cool idea. Something that's a problem is the FDA doesn't know what to do with combination therapies. If you do, they want you to do combination tests on things that you already have shown individually are safe and have some efficacy. But if we know that with a single treatment, we're never going to be able to show efficacy, we might be able to show safety, it creates a problem moving forward. So there's going to have to be negotiations with the FDA that allow us to test combinations that have not been tested individually in the future. I'm also not convinced that the people who fund spinal cord injury research are working together to make it as efficient as it should be. Since spinal cord injury clinical trials are so expensive, we're going to need help from NIH. And I've really become distressed that I think our stakeholders are not very nimble. You remember I was able to get my paper on the 2020 meeting out and published in 2 months. The organizers of that same meeting published a paper. It took them 2 years. If that's the pace at which they're going to organize a meeting where they expect people to come up with a therapy in 10 years, they just wasted 2 years getting their findings out. I've already kind of talked about this. Deep learning needs data, and it needs lots of it. The amount of data that it needs is decreasing because the people who are deep learning experts figure out how to use giant data sets like pictures of cats and dogs on the internet to train deep learning models, which then can be trained to recognize things like people's feet or elbows with much, much smaller training sets. And so that's good. But at the end of the day, for deep learning to work, it needs lots of data. So the open data commons for spinal cord injury, traumatic brain injury, we heard Adam Ferguson talk about that yesterday, are essential for computational scientists to help us move forward. I think that funding agencies need to demand that we make our data public, but it's expensive to do that. It takes work, and so they have to give us the resources to do that as well. Based on our own experience here, I don't think the spinal cord injury is a 2D problem. I think it's a 3D problem. And so I think any center that has 2 or 3 spinal cord injury people, they should have a light sheet microscope that allows them to move more quickly and more comprehensively. And those instruments change with time, so they have to be refreshed. And they're making crazy large light sheet microscopes that can image like a whole primate brain now. There are NIH-funded alliances trying to integrate a rehabilitation with preclinical research. And when I dug into these things, I previously served on review panels for grants in this area. They're very focused on TBI. And so I think that the spinal cord injury people need to jump on board and get more involved in these alliances. Wolf and I did have some things that we had slightly different takes on. So Wolf thinks that spinal cord injury is going to be a really, really rare disease in 2071, thanks to smart cars and smart helmets and gun control. And I think gun control, maybe in Canada. And I still think that guys are still going to suffer from Y chromosome disease and engage in risky behavior. So I'm not convinced that the number of spinal cord injuries is going to be dramatically decreased 50 years from now. I think neuroengineers are going to have spinal cord injury patients doing backflips in less than 50 years and maybe in less than 10 years. And Wolf thinks that people don't want to live inside a robot. And so he thinks that biological solutions are going to be preferred, and we have to keep working as hard as we can to provide them. Wolf thinks that neuroprotection cocktails are going to be with all first responders in an EpiPen-like device. And so that will help, along with things like hypothermia, to reduce the amount of cell death. And I would like to have one now. My wife would like me to carry one with me. Wolf thinks that we're going to be able to express stuff in growth cones, forget the soma. And I'm not convinced. I hope you can see this. It might not be high enough resolution on your monitor. On my monitor, we have a neuron, and we apply a chemical, and a growth cone races out of the soma down this neurite, and the neurite goes shooting off into the distance. So I think a lot of the actin and tubulin and other components to get really aggressive growth are going to be jumping out from the neurons. So I think we'll be treating neurons at the soma to promote regeneration and not just at the injury site. Wolf thinks we got to modify the scar. I say, well, maybe we could just put blinders on the growth cone so they can't see the inhibitory stuff. But at the end of the day, I really agree. I think we don't know enough about the scar. And it's not just the rodent scar. I think we're going to have to shift and start studying the scar in larger animals. I worry that the stuff that we're learning in mice is irrelevant to people, so we're going to have to really apply these amazing technologies to much larger animals if we're going to understand the scar the way we need to. Wolf says, yes, we need to understand the lesion much better. You can sometimes get axons to grow through an injury site, but it's usually when they're growing along some astrocyte bridges that have some favorable features, but we don't know what the features are of those astrocytes. So Wolf's really big on smart biomaterials, and he thinks that those are going to be really critical at the injury site. And so it's hard to argue with that. He thinks that we're going to have molecular tagging, a key-like system, get axons to grow to their correct targets. I actually don't disagree with him. I agree with him. I just want to name them after Roger Sperry because he was a cool guy. He thinks that rehab is going to be more effective and affordable through robotic training devices, neuroprosthetics, video games, and apps. I agree. I think that the epigenetics of rehab is amazing, and so all of those tools are going to help open up the chromatin and allow us to modulate gene expression to help axons grow long distances and find their targets. Do we need cell transplantation? Wolf says no. He hates the idea of cell transplantation. He wants to use endogenous stem cells. So that's our prediction. I was able to conclude in less than 15 minutes, so I'm very proud of myself. I talked to a lot of people. Like my wife, I have some OCD-ness, and so I spent lots of time talking to computational scientists. It was especially fun talking to this guy, Gerald Poet Salk, who's an expert in catastrophe theory. He applies it to all sorts of human diseases and changes in populations of fish. We have some local experts here. We collaborate a lot with members of the computer science department, like Ubu Visser, Zheng Wang, Stefan Wukti, to analyze our data. And then John Bixby, of course, reviewed my slide deck and made me take out the stupid stuff. So I thank him for that. I'm happy to try and answer some questions, but predicting the future 50 years from now is challenging.
Thank you very much, Vance. I thought that was incredibly informative and insightful, and I think you did a great job. So I think we all appreciate you going over all these very thoughtful points and trying to talk about where we are, where we're going. We'll open it up for discussion. Maybe Mary, would you like to start off the questions? I tend to call on people when I see their faces. While Mary's unmuting, you talked a lot about tools. Are our questions going to change, do you think, based on the tools and information? Are we going to be, in 10 years asking really different questions than we are today?
I had one slide about things, the stuff that we don't know if we know, right? And so we may, in the next 10 years, people doing lipidomics, for example, or looking at carbohydrates might develop evidence that says that those things are critical. So then we're going to have to start thinking about that and how they can be incorporated into the treatment strategies that we're developing. I do think that, we've known, I'd say, since 50 years ago, what a lot of the major questions were in the 80s and 90s. We learned the importance of inhibitory signals, not just in injury, but even in development. Many of the cues that guide axons are not attractive cues, they're inhibitory cues. And so it could be that we'll have a new conceptual breakthrough in the next 10 to 20 years that would change the course. And so that, that's the kind of thing that's impossible to know exactly where those kinds of changes are going to be. I think that I've seen how working with computational scientists has just so empowered my own research and John's in my lab, the kind of work like the Tassan did, that I think that as more and more biologists collaborate with computer scientists, and I think the younger generation has to become computer literate, and data scientists themselves to analyze their own data, it's going to allow us to move a lot more quickly. And so I think that that's great. Iggy, can you unmute Mary?
Yes. While you're waiting for that, this is Barth. Wonderful talk. I just wonder how you see the Miami project itself transforming into more holistic approach to repairing the nervous system rather than our initial focus, and the advantages of this approach I think are very evident today versus being totally focused on the crushed cord, so to speak.
So I think that lots of the problems that we're studying are relevant to things like traumatic brain injury and stroke. And so I think that, you know, that we're going to have lots of opportunities for collaborating with our colleagues in neurosurgery and in neurology. The technologies that like RNA-seq, which were first used in my lab, are now used in many of the labs in the Miami project. And so I think that, you know, I'm always kind of a tech person, and it drives my research. And I think that we will benefit by having colleagues using new, cool technologies that help raise the whole boat and make it easier for everybody to learn how to apply them to their own areas of research. So I don't know if that's a good answer for you or not.
Yeah, I think we've learned that 1 and 1 is 5 instead of 2, and it's been extraordinary to me the last few years, broadening the horizons and adding to the potential. So I'm excited.
I think Mary is up now. Mary?
Can you hear me?
Yes.
Okay. So Vance, that was wonderful. Thank you so much. We need more of this. I did find it rather depressing. In spite of all the wonderful new techniques and so on, we still have very basic problems remaining. You pointed out the funding challenge, the pharma challenge, the combination strategy challenge. So I've been so interested for the last 30 or 40 years about combination strategies, but how we overcome bringing the most important ones together and getting funding for it and so forth. I mean, we still have so many challenges, but I think what you've done is wonderful, and we need more wisdom from people like you. But how will we proceed? There's so many possibilities for proceeding, but what do you think is the next best step that could be taken for spinal cord injury? Of all the possibilities you mentioned, the biomaterials, and they're very promising, and the activation of stem cells, which I'm disappointed to hear because I didn't hear anything about Schwann cells today, but so be it. So I mean, there are so many possibilities for going ahead. What do you see as the next best step for trying to conquer spinal cord injury?
So I guess I don't know if I have one answer for that. I think that getting the funding agencies to be more nimble and cooperative is important. I believe that the private foundations are doing a good or better job of that. They're co-funding big things like the ODC SCI, so that's a positive. I think that there's a big problem with NIH when you submit a spinal cord injury grant to a neurotherapeutics program. It's competing with many, many other diseases. And so it's very hard to get the big hit of money that you need to develop a new drug. And I don't know how to to solve that problem, maybe using the DoD mechanism. But I just think that the DoD and NIH and those funding agencies need to work together more efficiently. And I know they talk to each other. The program officers for all those organizations get together, but they need to do a better job. And it's hard for me to know how to help them do that other than complain about it. I think that if I were given a large pot of money, I would use it to create some core facilities, to rigorously test promising things. This is not a new idea, right? It was done by the Miami Project and UC Irvine and Ohio State a few years ago. That was a burden because it was for academic labs who had to do these replication studies. I think that that's a core, like a CRO kind of opportunity. And I would also make sure that every spinal cord injury researcher has access to the latest and greatest cutting edge technology in imaging, because I think it can make their work go so much more quickly and test their ideas more rigorously. So that's something that I think could be done in the preclinical arena. It would not be cheap to do that, but I think it would be a more efficient use of resources.
So
go ahead, Larry.
Speaking of imaging, it's going to be important to keep in mind that we have to look carefully at the animal tissue. And I'm thinking about Rita Levi-Montalcini. One of her important characteristics was that when she was looking at the area of tissue in her experiments, she not only looked at that area, but she looked around in the neighboring tissue. And that perspicacity led to some of her discoveries. So we've got to think still about the tissue and the area around the tissue to see what the reactions are.
Absolutely. That's why I think these light sheet microscopes are so amazing, because they can allow you to look at the whole neuraxis in an animal very rapidly. And so the compounds that we're using in our lab are promoting sprouting. Are they promoting sprouting way up in the brain? Is that going to be a problem? We need to know those kinds of things. So absolutely, just drilling down and focusing on a particular region is not a good idea.
Alan?
No, I was just, going to say that phenomenal and inspiring talk, like Mike Wang said. Since it's neurosurgery grand rounds, I know that you talked about some landmark publications in 50 years ago. One that you didn't talk about, I think you were more West Coast than East Coast, was Albert Aguayo and Peter Richardson's work almost 50 years ago, not quite. But the reason why I wanted to mention it, was one of the first demonstrations that CNS axons can regenerate in a peripheral nerve environment. And the reason why I wanted to bring it up in neurosurgery grand rounds is that was all fueled by a neurosurgery resident, Peter Richardson, who was at the MNI and then ultimately ended up in England. But it just goes to show you that for the residents who are still on the call, that, you can make a difference, if you dedicate yourself to a specific question, even during your training. And so that's an encouragement for those people to continue to move things forward.
Yeah, so that's my fault. We actually had that point in the slide, and that was something that Wolf talked about. So I that wasn't in my memory banks to hit on that. But I heard Albert Aguayo give a talk about that when I was a postdoc, and it was like the most exciting thing in years. So it was super cool. Another example of a neurosurgeon who had a huge impact was Irv McQuarrie, who discovered the conditioning effect of a crushed nerve, and how when you crush a peripheral nerve, it can make CNS axons regenerate when they don't do that. And so that has set off decades of research. And so absolutely, neurosurgery residents can have a big impact because they're the people who see the problems firsthand.
Vance, Mike Wang had a question on chat. You talked about single cell sequencing. How about single cell genetic engineering?
I think we're going to be able to do whatever we want. For sure, absolutely. We'll be able to do single cell genetic engineering on layer 5 corticospinal tract axons just by using the right kind of promoters and blah, 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 blah. I think that that's not 50 years away.
Very good, very good. Any other questions just about Schwann cells? Our paper that was just up on PubMed yesterday on the results of our chronic human Schwann cell spinal cord injury transplantation study that for the first time combined cellular therapy with rehabilitation was out. And please take a look at that. That's a really outstanding effort by a lot of people over many, many years. Dr. and Mrs. Bunge, Dr. Bunge, Dr. Richard Bunge, Dr. Mary Bunge, and a lot of colleagues in the past. And it really turned out, I think, very important to show that you can do these very complicated cell therapies in people. They're safe and interesting data. And we're going to spend the next probably couple of years evaluating that data in different ways, electrophysiologically and psychiatry in terms of what the patients feel and things of that nature, autonomics and things like that. So I think it's a great start to continue to think about how we build a road to curing paralysis. So anyway, any other questions, please?
Well, let's congratulate Vance again, because
Thank you very much, Vance.
That
Great
was
job.
a super job, and we need more of that, and keep it up.
Thanks for giving me the chance to give grand rounds on this.
What is pattern recognition problems? When you say something like that, what do you really mean?
So that's what deep learning is really good at. It uses these recursive neural networks that you're able to train them to recognize what are the features of a cat's face or a cat's paw that are different from the features of a dog's face or a dog's paw. So that's a pattern of pixels in 3 colors that these algorithms can be trained to learn if you give them lots of annotated data. So you have to give them like 1 million pictures of cats and 1 million pictures of dogs, and the cat pictures have to be pre-labeled with cat, and the dog pictures have to be pre-labeled with dog. And after a while, it'll be really good at being able to predict whether a new picture is a cat or dog. So that's a pattern recognition problem. So if we have patterns of data of kinase inhibitor patterns, and we categorize them by hits or non-hits, the pattern recognitions will be able to recognize, just based on the biochemical profiling data, whether a new compound is likely to promote axon growth or not. Does that answer your question?
Yes, it does. Yes, it does. You know, the machine learning and big data, we had a very successful defense of Hannah's PhD dissertation yesterday. It was all on big data and machine learning. And as you get into that area, it's just so much potential, but it just requires so much data and expertise that kind of appreciate the biological questions as well as the computer questions. So analysis questions. So anyway, I think it's a great future. And anyway, the project is going to be focusing on that. And we're trying to bring in more biomedical engineers to the project and to the Lois Pope Life Center. So I think some of the things that you talked about, Vance, are very timely in terms of how we're going to try to create the right scientific environment to advance that science and productivity and discoveries. So anyway, with that, I guess we have to say goodbye. I guess people have things to do. But Mary, great seeing
I'm free.
Great seeing you, and great talk, Vance. Thank you very much. Bye.